said, Alison is a fellow and executive director at the Institute of Health Visiting in UK. And we all have in the region very positive experiences with the Institute, and we are very grateful for their support during the years. She has extensive background in health visiting practice, home research and leadership. It's very problematic with terminology. Some people use health visiting practice, some call it home visiting. So I'm going to switch between the terms, and I hope it's okay. So she has also extensive background in research, leadership, and policy. Sorry, she's driven to ensure that every child has the best start in life, and we hope that she will illustrate through her presentation how can we harness the power of home visiting to give every child the best start in life, that we are going to see how she sees how home visiting can make her dreams come true. So welcome, Alison. Thank you for being with us, and the microphone is yours.
Oh, thank you very much, Sarita. Can you hear me? Yes. So thank you. It's a huge privilege.
Thank you.
Thank you. It's a huge privilege to join you today. And it's wonderful to know, isn't it, that there is a global community of like-minded people who all have either seen firsthand the power of home visiting or are interested enough that you want to find out more. And thank you for that kind introduction to my resume of my career. I'm very lucky. I feel like I've had a very varied career. I am a health visitor. I spent pretty much my whole career doing health visiting, and I'm very proud to be a health visitor because I've seen firsthand the difference that it makes to families. So the session today is harnessing the power of home visiting, or put very simply, what's the problem? Why does it matter? And how does home visiting provide an important part of the solution? So in my career, I've worked with thousands and thousands of families, and I've learned so much from them. I feel very privileged and thankful to them. I'm also, as a personal note, I'm a mother of 3 children, and my middle son was born preterm. He's got cerebral palsy. So I've also learned firsthand from him and that experience. Unexpected things happen in life. And 2 very important truths. So the first one is that all children have hopes and aspirations. But sadly, we know from the evidence that some children are much less likely to achieve their dreams and aspirations than others. Disadvantage starts early, the effects are cumulative, they can last a lifetime, they can pass from one generation to the next if they're not addressed. The other truth is that actually all parents, every parent that I've ever worked with, wants the very best for their child. But we know that being a parent can be challenging, and there are thousands of reasons why life doesn't work out the way that we hoped. As I said, unexpected things happen. You might have a preterm birth, a sick baby, a disabled child. Life can be much harder if you're experiencing a mental health problem yourself, or you have other challenges like domestic abuse or addictions. And this can all impact on child outcomes. But fundamentally, inequalities are not inevitable, and we must never lose sight of that. So if we want to change things, we need to face up to the challenges, but we also need to embrace the opportunities, of which there are many. Every country will be slightly different, so your challenges will be slightly different. But fundamentally, there are some key themes that we all share. So on this slide, I put out the challenges. Many of us experience widening inequalities, and groups of children still have a very poor state of child health and well-being. In England, we're very concerned about rising levels of invisible, vulnerable children, and the pandemic has made this worse. Children with unidentified need who aren't getting the support that they need. And we know that the cost of failing to intervene is enormous. But in terms of opportunities, we actually have more evidence than any other generation that the early years lay the foundation for lifelong health and well-being. We know that investment in the earliest years of life is a smart investment. We know enough about what works to know that early intervention can make a huge difference, and inequalities are not inevitable. And for health visitors or home visitors, these are a highly skilled workforce that's well equipped to make a significant contribution to numerous government priorities for child health and well-being. So what are universal home visiting programs? We've heard a little bit about it already. The aims are to support healthy pregnancy, improve early childhood development, so all 4 of these WHO recommendations, to ensure readiness for school, and to reduce health inequalities in young children. It's a universal prevention program of early intervention, provides public health services to all families with children from pregnancy to the age of 5. And the fact that it reaches all families is a huge benefit, because actually there's no stigma then. Everybody has a health visitor. It doesn't work from a medical model. So it's the philosophy is really about health creation. It's strengths-based. Nobody starts with nothing. Everybody's got strengths. Building on those, seeing the person in the context of where they live, and pivoted around these 3 core practices of home visiting, needs assessment, and working with others to find a solution for each individual family. So what kind of a workforce do we need to do this very important work? This does vary a bit depending on the country, as Aritza has already said. But most importantly, what we need is a workforce with practitioners with the skills to work in partnership with families and to address these key public health priorities. So we're talking about adult health and child health, physical health and mental health, child development, social needs, and safeguarding. So the remit is quite broad. In the UK, this role is done by a qualified health visitor. So they have a registered nurse or midwifery background. They've then gone on and done additional study, which is now actually at master's level. And the profession and its standards are regulated nationally by the Nursing and Midwifery Council. The way that the service is delivered varies by country, but generally it looks something a bit like this, with similar key elements set out on this slide. So starting from the left-hand side, we need a national framework which sets out the blueprint for the service. We set out an example in our vision for health visiting, which we published in 2019. All families in the model will get a number of universal contacts. So in England, some families will get 5. In other parts of the country, they get more. In Scotland, it's 11. And then families who have identified need will then have additional support tailored to their specific need. Fundamentally, the needs of the child and the family remain at the center, and the relationship that they have with their health visitor is crucial. This is not a friend. This is a professional relationship built on trust, built up over time. And then the content of the work that they do is focused around these high impact areas where the evidence says health visitors can make the biggest difference. So things like transition to parenthood, perinatal and infant mental health, supporting child development. I won't read them all out, but all driven by evidence, evidence that early intervention makes a difference in these areas. So when we consider the mechanism for change, so how are we going to change things, it's really important that we are reminded about how outcomes are made in the complex and messy real world. And to do this, we need to think about systems, complex systems. The world is complex, people are complex, not one of us are exactly the same. So our solutions will need to take account of this. And the example I put on this slide is childhood obesity, but it applies to any of these issues. They're all costing the government a fortune. And just telling people to eat less for obesity and exercise more, we know it doesn't work. It's too simplistic. It's not cause and effect. We need to think about systems. So on the bottom left-hand side of that slide, you'll see what's called the Foresight Obesity Complex Systems Map. And I don't expect you to be able to see it. But you can look at it later. But there are 108 variables and 300 causal links that cause obesity. And we're all affected differently. So in that respect, our solutions need to take account of the child at the center, with the family around them, their wider community, their population, to look at what are the drivers for this family at this time, and to find a solution that works for this parent and for their child, not just any child. And this applies for every of these high impact areas on this slide. And as I said, they're all costing a fortune. Outcomes are also made by taking a proportionate universalism approach. So there's a simplistic view that we just focus on the most vulnerable. But actually what the evidence says is that this will not reduce health inequalities sufficiently. There's lots and lots of evidence to support this. A great quote from Sir Michael Marmot on this slide, that actually focusing solely on the most disadvantaged won't reduce health inequalities. What it does is misses the opportunity to reduce the whole social gradient across the whole population. So on this slide, I've put a graph which is childhood obesity, but you will have exactly the same graph for a whole raft of other public health challenges. So it might be accidents, childhood accidents, oral health, speech and language development, broader child development. They're all socially driven. So if we focus only at this end on the most deprived decile of deprivation, what we do is we're missing out on all of these children here who are all affected to a greater or lesser extent. So what we need is a universal service for all families, early identification of need, and then additional targeted support for all of the children who are affected. How we work matters too in the complex and messy real world. And health visiting is much more than just an intervention. So not just these purple things, chevrons I put on this slide. We need to think across the whole pathway. And many people have described it as a vital infrastructure for the early years. So we need to start up here. Someone's talked pathways already with prevention. So ideally stopping problems happening in the first place. An example would be fetal alcohol spectrum disorder, 100% preventable, very hard to treat, but definitely worth it because children are significantly impacted if they aren't treated. Secondly, early identification of need is absolutely crucial. You can't do early intervention without it. But what the evidence tells us is that there are many barriers to identification of need. Some families will have multiple and coexisting problems. They don't even know where to start some of the time. They may feel stigma or shame. They don't want to reach out and ask for help. Maybe they don't know that help is available for them. Maybe they don't recognize they have a problem or that their baby is in distress. So what they need, and this is really important, is a practitioner with the skills to get alongside them, to understand the world where they live, to build a trusting relationship where the parent shares the things that really matter, and then with the skills to sift through the detail of their life with them. You're getting a set of outcomes in this life and all the variables around you, and to help them to imagine another world where they maybe get a different set of outcomes and the steps that they need to take to get there. And that's really important. And the other thing is we know that the families that need help the most are often the least likely to reach out for help. And they are the most likely to drop out. Highest rate of attrition. So we need to build a service that expects that. We need a safety net around these families. Babies are citizens in their own right. And we need services that reach out to them, which is really important. And again, relationships are key if we want to have improved outcomes. Proving impact in a complex world can be challenging, but it's definitely not impossible. And there's growing worldwide evidence that prevention really is better than cure, and early action leads to cumulative savings. It also reduces pressure across other parts of the health and care system, both now and long into the future, and has wider system benefits, really through the early identification of need. And so on this slide, I've just put two examples, but there's lots across the globe of evaluations of what you would call intensive home visiting, universal home visiting. This is the one from England, which is in 2016, which looked at the National Health Visiting Programme, which found statistically significant improved outcomes in many relevant areas. And this is a more recent one from Scotland. So they have just increased their offer in Scotland to 11 universal contacts. And what they found was that they had reach across all socioeconomic groups. The additional reviews identified concerns for children that hadn't been previously flagged. So these are vulnerable children that would have been invisible if the service hadn't been there. And parents reported positive outcomes. They felt better able to ask for and accept support that was on offer. So as I come to a close, I just want to summarize, if we want to drive change, we need to do it with the evidence and focus around these three key priorities. So firstly, quality. We need a national framework with agreed goals and outcome measures. workforce. We need the right workforce with the right skills in the right number, with the right training, with supervision. And this needs to be calculated at a national level with demand-driven workforce modeling. And we also need sustainable funding, investment to save. We need a shift from the way we see spending on babies, young children and families as a cost. And instead, we need to see this as one of the smartest, if not the smartest of all investments, and investment in our human future. And so I want to leave you with this beautiful picture on my last slide, which I think speaks 1,000 words. It looks to the horizon, it looks to the future. What kind of a future are we hoping to build for our children? It speaks of inclusion and it speaks of hope. There's a quote from the Duchess of Cambridge, now the Princess of Wales. She's very interested in this work. She does a lot of work in early years. And she said, is it a brave thing to believe in an outcome in a world even that might not be fully felt for a generation or more? And actually, I call on everybody that's here today, it rests with us. We are the adults in this world, and we are the people that can make this happen. So I'm going to hand back over to you, Ritza, and very happy to take questions. Thank you.